In this session, we are going to be looking at the topic Levator Ani Syndrome. Hi, I'm Sharon. I'm working as an assistant professor at College of Nursing. The following are the objectives that will be addressed in this session. Levator Ani Syndrome, LAS. It is a type of non-relaxing pelvic floor dysfunction characterized by chronic anal pain. Means the pelvic floor muscles are too tight. The pelvic floor supports the rectum, bladder and urethra. In women, it also supports the uterus and vagina. It is a functional gastrointestinal disorder, affects approximately 7.4% of women and 5.7% of men, and usually affects the age group of 30 to 60 years. The other names of Levator Ani syndrome are chronic anorectal pain, levator spasm, pelvic tension myalgia, piriformis syndrome, and puborectalis syndrome. Let's look at the etiology of Levator Ani syndrome. The exact cause is unknown, but may be related to any of the following: childbirth due to large incision, vaginal tears, delayed bowel or bladder emptying, chronic tension of the pelvic floor muscles, vaginal atrophy or vulvodynia, continuing intercourse even when dyspareunia is present, injury to the pelvic floor from surgery or trauma including sexual abuse, inflammation in the pelvic area, having another type of chronic pelvic pain including inflammatory bowel syndrome, endometriosis or interstitial cystitis, dyssynergic defecation, where pelvic floor muscles including the puborectalis muscles do not function as they should. So this may play a role in the development of the syndrome. History of hemorrhoids or anal fissure, colorectal or gynecological surgery. Let's address the clinical manifestations of Levator Ani syndrome. Rectal pain, which is not associated with having a bowel movement. It's usually irregular and spontaneous, brief or lasting several hours or days, brought on or made worse by sitting or lying down, dull ache, sense of pressure in the rectum, and it may disrupt sleep. It's usually felt higher in the rectum. One side, often the left, may feel more tender than the other. Low back pain that may spread to the groin or thighs. In men, pain may spread to the prostate, testicles, and tips of the penis and urethra. Urinary and bowel problems such as constipation, tenesmus, that is painful defecation, incomplete evacuation, bloating, urgency of urine, painful micturition, and urinary incontinence. Sexual problems. In men, there can be painful ejaculation, premature ejaculation, or erectile dysfunction. In women, there can be dyspareunia, that is painful sexual intercourse. Let's look at the diagnosis by using a proper history collection. Diagnosis by exclusion, that is when doing GI examination, predominantly digital rectal examination, and other GI diagnostic measures. Where other problems are ruled out, then we can conclude that patient might be having LAS. In men, LAS is also often misdiagnosed as prostatitis. These are the other diagnoses that I spoke about earlier. So this has to be ruled out before concluding LAS. They are inflammatory bowel disease, anal or rectal abscess, anal or rectal fissure, thrombosed hemorrhoids, prostatitis, coccygodynia, prostate cancer, and colon cancer. Management is by performing sitz bath, doing exercises to lose tight pelvic floor muscles, just deep squat, happy baby, legs up the wall, and belly breathing. Use of a donut pillow to reduce the pressure on the anus. Physical therapy including massage, heat, ultrasound, and biofeedback with a therapist who is trained in pelvic floor dysfunction. Muscle relaxants or analgesics such as cyclobenzaprine, gabapentin, and pregabalin. NSAIDs, trigger point injections which may be with a corticosteroid or botulinum toxin, that is Botox, acupuncture. Nerve stimulation can be done by EGS, that is electrogalvanic stimulation. It involves inserting a probe into the anus to administer mild electrical stimulation and TENS. Sex therapy. TCAs, that is tricyclic antidepressant, should not be used as they may aggravate bowel and bladder symptoms. The following are the references for this particular topic. Thank you for your patient listening.